I am Matt Ewald. I serve the Texas Tribune as Senior Director of Events and Live Journalism. Welcome to those joining us in person here in Austin and those joining us online for our conversation today titled 5 Years After COVID-19, Is Texas Better Prepared for the Next Public Health Crisis? Today we're joined by John Hellerstedt, MD, former Commissioner of the Texas Department of State Health Services, and David Lakey, MD, Vice Chancellor for Health Affairs and Chief Medical Officer for the University of Texas System. They will be in conversation today with my colleague, Terri Langford, the Texas Tribune's Health and Human Services reporter. Our program today will run an hour with 45 minutes of moderated conversation and 15 minutes of Q&A. So that we can get to as many questions as possible today. We're going to be doing all Q&A through our Q&A portal at texastribune.org/ask. That's texastribune.org/ask. For those who are here in person, you will also find some signage around the room with a QR code that you can scan to get to that Q&A form. We also do have, if you want to go old school, some note cards that you can ask your questions on, and we'll collect them. We are always grateful for the support of our sponsors. Our major sponsors for today's program are Methodist Healthcare Ministries and Texas Hospital Association. Though corporate sponsors and donors underwrite this event, they play no role in determining the content, speakers, or line of questioning. We also want to thank our host, UT Health Houston School of Public Health's Austin campus, not only for hosting us, but for opening up their teaching kitchen, their Nourish teaching kitchen today for our in-person attendees. I want to give a shout out to Carolyn, Casey, Caitlin, and Jerry for providing those healthy snacks for us today. And also here to offer a welcome on behalf of the school is Deanna Helsher, Regional Dean of UT Health Houston School of Public Health's Austin campus. Dean Helsher.
Thank you very much, and I'm so excited to welcome you all to this great event today. I would also like to express my appreciation to the Texas Tribune for sponsoring this and having this here in our location and visiting with two former commissioners from the Texas Department of State Health Services. The University of Texas Health Science Center at Houston, or UT Health Houston School of Public Health, is the #1 ranked School of Public Health in Texas and the #9 ranked School of Public Health that's publicly funded in the U.S. So the School of Public Health is really unique in that in addition to our home base in Houston, we also have campuses in Dallas, San Antonio, El Paso, Brownsville, and here in Austin, where we all are. So the UT Health Houston School of Public Health in Austin has a mission to address public health needs in Central Texas as well as the state. Our regional locations really give us an opportunity to span the state in this regard. The campus here has a total of 21 faculty members and 150 students, most of whom are pursuing dual degrees with the University of Texas at Austin. We are also home here to the Michael and Susan Dell Center for Healthy Living. So our vision for the center is healthy children in a healthy world. But we know you can't have healthy children and families without healthy communities and a healthy state. And so we do our best to promote that through research and programs in nutrition, culinary medicine, we've mentioned the kitchen here, physical activity, mental health, tobacco prevention, maternal and child health, and amelioration of food insecurity. So together, we're really happy to welcome you today, and we look forward to seeing what solutions we can help you pursue to address the public health challenges of tomorrow. Thank you.
Dean, thank you so much. We also want to thank all of you around the state who make the journalism of the Tribune, including events like this, possible. by becoming Texas Tribune members. Let's just see a quick show of hands for those here in Austin who are members. Can you raise your hand? See several around the room. To learn more and become a member, you can visit texastribune.org/support. I also want to mention that tickets are now on sale for the 15th Texas Tribune Festival, November 13th through 15th here in downtown Austin. TribFest isn't just another political event, it's where big ideas meet real action. As an attendee, you'll join conversations shaping the future of education, the economy, healthcare, energy, technology, public safety, culture and the arts, and more. Tickets are on sale now at tribfest.org. Later this month, on Tuesday, April 22nd, at University Medical Center in Lubbock, we'll host a conversation focused on how we strengthen maternal health care in Texas. We'll examine the successes and struggles of strengthening maternal health care in rural Texas communities from the people who are on the front lines, and hear about how improving women's health outcomes helps everyone, no matter where they live. You can learn more about these and other events around the state at texastribune.org/events. Now let's get to today's program. Dr. David Lakey is the Vice Chancellor for Health Affairs and Chief Medical Officer at the University of Texas System and Professor of Medicine at the University of Texas at Tyler Health Science Center. He was Commissioner of the Texas Department of State Health Services from 2007 to 2015, and in 2014 he played a key role in the state's response to the first Ebola case in Texas. Dr. John Hellerstedt is the former medical director for the state's Medicaid and Children's Health Insurance Plan, and he served as Texas Health Commissioner from 2016 to 2022 and led Texas' response to the COVID-19 pandemic. He also served as the Chief Medical Officer for the Seton Healthcare Network. I thank both gentlemen for being here with us today. Thank all of you and those online. And with that, I turn the program over to my colleague, Terri Langford.
Thank you so much, Matt. Thank you for all of you coming today. This is a super important topic. It's something that we've dedicated a lot of coverage to, and really looking forward to this conversation. I would ask, just make sure everyone's cell phones are turned off, and we are going to have plenty of time for questions at the end of this. I'm thrilled to have both these men here. I have covered them for years. I have covered their agencies for years, and just thrilled that we can have this kind of conversation. When Texans wake up every morning, public health has been hard at work for all of us. It's the safety net that makes America and Texas run day to day. We have clean drinking water, plumbing, waste disposal systems, safe food to eat in our refrigerators and in our store. And that's thanks to the hard work of public health. It's an invisible safety net no one pays attention to until it's a pandemic or an outbreak or a mass evacuation from a hurricane or even a measles outbreak. So, yet we have seen very little spent in this state over time on public health. It comes out to about $20 per person. And we're 39th, sad to say, in public health spending. That's been a problem for years. Despite all this, Texas came through the pandemic, but not without some scars. We lost some 80 to 90,000 people. We have a lot of people who are still battling illness, and we still have death of COVID, yet it has been reduced tremendously. So let's talk about sort of where we are today and some of the lessons that we've learned. My first question to both of you is, we made it through, but is just getting through a pandemic enough? What are, could we have done this better? Or is this an event that no one was prepared for and did well? I'm wondering if you can start with us, Dr. Hellerstedt.
Yes, hi, I'm John Hellerstedt, and I really do want to thank you all for being here. I want to thank the Tribune for hosting this. It is very heartening to see that there's so many people who are interested in this topic, because it's been 5 years, and in the minds of a lot of people, they just sort of want to put it in the past. So to your question about, could we learn from it? Well, absolutely. And I really think we haven't put enough effort into learning from it. So we just passed through essentially an existential trial, and in my opinion, came out on the other side. Look around, we're not only intact as a society, which was at risk during the pandemic, we're not only intact as a society, but we are thriving. But we could have done it better. We could have optimized it better. And I really would like to see the thing about the pandemic that makes it different than ordinary public health, the things that you mentioned. The pandemic was an all of society emergency, and it required an all of society response, and especially the role of elected leadership is extremely important. I would love for us to have some organized and formal way to be looking back at the pandemic and look at it in the way that war colleges look at wars, okay? What do? They
That's
look
right.
at,
We haven't had a postmortem on this yet.
we have not had a postmortem. Those colleges look at every aspect of it. They don't just look at arms and armament. They look at economics, at history, at leadership, all aspects that they either did contribute to one outcome or didn't. We need to do that, I think, with the pandemic. And if we really want to understand how to face the next inevitable emergency. There's a great book called The Devil Never Sleeps by, I think her first name is Christian Kayam. She's into emergency preparedness. And basically, we live in such a complex world, we will face some serious emergency that requires an all of society response. We're not prepared for that. Then the other question has to do with basic public health, but I want Dr. Lakey to make his comments.
Well, again, first, thank you for inviting me to be part of this. And thank you, John, Dr. Hellerstedt, for your leadership during the pandemic. I think kind of building on Dr. Hellerstedt's comments, when I was commissioner, one of the things I realized is that it was my expectation that we would have one event of national consequence per year in the state of Texas. And that held true.
Yeah.
H1N1, Hurricanes Ike, Gustav,
Ebola.
et cetera, Ebola, West Nile,
Swine flu.
swine, yeah, H1N1, the list. Every year, Texas will have to face some type of event of national consequence. It'll be in the national news. Because of that, though, I think Texas has a lot of experience in management of disasters. And so this was an infectious disease disaster, but I think we handle that in Texas in the overall emergency management system of the state of Texas. And we have a lot of experience there. And so one of the things that I think Texas does well is it brings the key players and the agencies together, working with the governor, with the leadership. We as commissioners have a role to play, but it is an all of society type of response. And I think we did that probably better than some other places in providing that expertise. But there will be another event, and when it starts, it will be a little messy when it starts. It will impact the hospitals, it'll impact healthcare, but we get together and start figuring things out, working with legislatures, work with the private sector, state agencies to figure out what do we need to do together to be able to respond.
Thank you. This really helps key up to the next question. This has been a very tough year already on public health. We are watching a slashing of funds, clawback of funds that have been given to local communities to fight all kinds of chronic illness or health problems on the local level. In fact, some of the funding that is going to the Lubbock area right now for measles has been part of this clawback, has been earmarked that it will be discontinued in 30 days. We've seen tremendous layoffs in the HHS system, and that expertise is going away. What do you feel like, I mean, as two people who have devoted their lives to public health, what do you say to encourage people to either bring attention back? What can we do to bring attention back to public health? Do you feel like this is no longer top of mind? We're past the pandemic. What are you feeling from lawmakers right now? It's sort of like, this is yesterday's news. How do we go forward and still grab the attention of lawmakers that this is an investment that's just as, important as, say, an economic development fund to bring new business to Texas. I mean, how do you sell public health in an atmosphere that's become increasingly more partisan? I mean, how do you do that balancing act, Dr. Lakey and Dr. Hellerstedt? What do you say to to lawmakers right now who have doubts about it?
So if you look at businesses
Right.
and their bottom line, a big chunk of their costs go to healthcare costs. And if you have an unhealthy population, that drives up your healthcare costs. We did an analysis many years ago about East Texas and compared it to the rest of the state, and it was significantly, the health statistics were significantly worse than the rest of the state. It was interesting to me that the people that carried around that analysis, and they pull it out of their briefcases, were the business development people in East Texas.
That is so interesting because that region has tried for decades to get bigger employment centers in that area. So that's super interesting.
Yeah, there's a direct relationship between how healthy the population is and the cost of any type of business. And I think that's part of this, the economic component. I think many of the things that we do really do have bipartisan support, whether it's fighting HIV or birth defects or, one of the things, and there's people here that do work related to improving the health of mothers and babies in the state of Texas. I think those, and we do work related to mental health. I think all those things get bipartisan support. And, we have seen increases in our, we the 39th, but we have seen increases in our budget, which is different than a lot of other states that have seen decreases in their budgets related to public health. I was encouraged that the legislature put in the full ask related to a new state laboratory here for the Department of State Health Services. They do really important things in that laboratory, but they got full funding for newborn screening and expands the ability for doing a variety of other tests. And you don't necessarily see that kind of investment occurring in other parts of the nation.
Dr. Hellerstedt?
And Terri, I absolutely yes to everything that Dr. Lakey said. I would add to that, I wish that everybody in the room could write down what the things that you listed early on that are some of the very basic functions of public health, of keeping the water supply safe and things of that nature. This is the basic infrastructure that enables us to drink water out of the tap and not have to worry that there's something there that is deadly. The other thing to remember is that all of this occurs, and I've seen this in various state agencies. All of the things that they do are their own, if you will, deep well of complexity. And so what you need in order to operate that efficiently and effectively is people with skills that they learned on the job, and they came up from an entry-level position, demonstrated their skill and ability, learned more, demonstrated their ability to be a leader, and then were taking over and managing these complex functions. That's manpower, that's woman power, that's expertise. And what worries me the most is that we're short-shifting that, or at least at some level there's a sense that that these agencies are bloated or whatever. I'm not sure I'm feeling that quite so much here in Texas, but on other levels of our government, there's just this sense that you don't need these people. What do? Well, what they do is that they have great expertise and they coordinate the activities. So again, we have a problem with congenital syphilis in this state. And the only way that you get a hold of that is to get a hold of the rate of syphilis in the community. And the only way you get a hold of that is through contact tracing and meeting with people. That takes a human being, that takes person-to-person contact, that takes a great deal of skill and patience in order to get done. So if we're serious about protecting babies against this otherwise completely preventable threat, we need to understand the role that public health plays in doing that.
One of the other things I kind of think about is, so when I became commissioner, I was playing with some numbers this morning. When I became commissioner back in 2007, the population of Texas was 23.8, okay? We're now, I was looking at some data saying that we're probably at 32-ish. So you've basically added the population of the state of Washington, the state, to the state of Texas. And so that's a huge increase in population. And with that, there's more hospitals that have to be put into place. There's more restaurants that get put in place. More of that infrastructure for those 32 million individuals. And there's a role of the state health department to make sure that that's done right and that the hospitals are safe, the restaurants pass inspection, all those things are done in a way that's behind the scenes, but can keep us healthy.
And if I might comment, just for people's background, I think some people will know, others may not, but health departments are organized differently in different states. So for instance, in Florida, there's a state health department and they really do all public health throughout the state. That is not the case in Texas. In Texas, where a city or county or other municipality has a health department, they answer to that local government. They answer to the mayor or the county judge. They have a lot of liaison with the Texas Department of State Health Services. If there's a public health service they don't offer, we pick it up. But I want to say I think it's a really good system in the sense that it follows the notion of subsidiarity. In other words, those local people know their communities very well, and they're going to know better than I might, for instance, in terms of how to approach the public health needs of their community. We work with them very closely. We have funding relationships. We have programmatic relationships with them. But just so people understand, the Texas Department of State Health Services has an overall responsibility, but it's not the operator of public health in every community.
No, it's a really important point. And it's a challenge, too, for the reporters who have to write about it, I can tell you that, and trying to explain it to people because, yeah, if you think your inbox is something, you should see mine. I'd like to know from both of you, does public health is public health or what we're watching now out of the pandemic sort of a branding problem? It seems like public health took a real beating. It became sort of part of sort of the conversation that were going on during that first summer and until we got the vaccines. And then people clamoring for a vaccine, we get a vaccine, then people are questioning the vaccine. We are seeing a rise in vaccine hesitancy, and we are seeing a rise in exemptions in the state. And we are now seeing diseases that we haven't seen in decades come back. Is there sort of a repivot for public health coming out of the pandemic? What does the public health community need to do to put it as sort of top of mind of lawmakers, and that this is as important as it should be part of your state economic development plan? I mean, how do you combat this sort of blowback we've seen on public health? I mean,
well, first of all, I'd like to say I think here in Texas, I think we handled the pandemic very well, frankly. It's not perfect, but there's no such thing as a perfect response to an emergency, because you have to remember every time you have an emergency, it means that everything that you did to try and prevent that emergency from happening failed. And so you're in a failure mode, which is a chaotic mode, and chaos risk catastrophe. I think we had excellent leadership in Governor Abbott. I remember when I briefed him for the very first time on January 20th of 2020. And I told him, sir, basically the risk is to your hospitals. The risk is that your hospitals will become so full of sick COVID patients that they won't have room for anybody. And to his credit, he immediately understood. He always understood the medicine. He always understood the science, the public health science, and he never pushed back on any of that. I think the branding problem that you're kind of talking about, I don't think that stems from Texas. I like to think that when I retired in 2022, which was the end of the emergency phase, the pandemic, we had gone through this with a good, solid reputation. So, for instance, the woman who was the chair of the expert vaccine allocation panel, Imelda Garcia, actually was recognized formally by the Texas Senate for her incredible skill in not only figuring out what the priorities were for vaccinations, but they also had a tremendous role in the logistics of getting these vaccines out to folks. And here you all of a sudden have this, and we couldn't use the existing vaccine distribution that we had because this was a vaccine that required ultra cold supply chain throughout the whole thing. Well, guess what? These folks succeeded in doing this. So I think, again, that Texas did it very well. We had some very close calls with our hospital capacity on 4 different spikes that occurred throughout the emergency phase of the pandemic, but we managed to handle it. And again, I'm very glad Texas Hospital Association is part of the sponsorship here because their response was really amazing, not just in the ability to take care of those sick patients, but we had to rely on them to be the first clinics that administered the vaccine when it was brand new. And we knew that the demand was very high and the supply was very low. Our first priority was to vaccinate everybody who worked in a hospital who was willing to get vaccinated. So I know I kind of strayed from your answer, but those were points I wanted to make. So.
No,
So I think, Terry, if we did a survey in this room and had the people define what public health is, I bet I would get 20 different answers. And I think that's part of the challenge, is that sometimes public health is seen as publicly funded healthcare,
right.
okay? Or there's people here that are working in the school of public health, developing the science related to public health. John and I worked in governmental public health, and I think sometimes then that gets conflated with overall government and distrust of government, et cetera. You know, when I attend meetings with other commissioners, you know, sometimes it was interesting to me that the definition of what is in public health was very different in different states. Mm-hmm. And then a variety of societal issues get labeled as this is a public health issue, and all of a sudden public health is everything that anyone is working on. And so I think it's important when you're in governmental public health trying to figure out what the lanes that the legislature wants us to do, what the governor wants us to do related to health. I do think in these events that sometimes I think one of the key components to response is communication, and that sometimes the governmental public health person isn't necessarily the person that needs to be up in front of the camera. I think one of the things that was done well was with having the governor up because it's a societal issue and it's pacing the economy, et cetera. I also think it's important people trust their local doctors. And so working with physicians to make them the spokesperson as you give them the right information is important. Because I think one of the challenges we have right now in this whole conversation is trust. You know, do you trust the messenger that's providing the information? And a lot of work takes place to work with faith communities and others so that there's a trusted face. And I would say that looks like the community, that's talking to the community, that's giving the information that is credible, evidence-based, related to any kind of response.
Do you think that over time, I mean, we have had health emergencies, like you say, there's always some sort of health emergencies have become part of the breaking news cycle, and it's getting faster and faster and faster in the last few years. Do you think, what would you, moving forward, what would you like to see that you don't see now in kind of making the case with the public and kind of talking to a lot of people who have come out of the pandemic very distrusting? It is a lack of trust right now. What is it that you see that public health can do to bring back a trust in public health? So
again, if what we're talking about is the emergent crisis situation, that's very different from the day-to-day activities of public health, which we all know. The emergent crisis situation is an all-of-society response, and the role of elected leadership is, in my mind, paramount. They need to engage in effective crisis communication, and crisis communication is a discipline in its own right. Again, I think we did a pretty fair job of that in Texas. So, for example, I don't know if I made the message clear enough during the pandemic and during the times I got to stand up in front of the camera. But the risk, again, was about hospital capacity. And that meant that you had to suppress the prevalence of the disease in a community to the extent that on any given day, hospitals had the capacity to manage that care. In order to do that, you have to have effective crisis communication. And the leader needs to say, and I think it did work in Texas, I would be sitting next to the governor. I think the way it was set up, it was very clear. The governor was getting really good advice, not just from me, but from lots of other sources in terms of the science, the public health, the medicine. But it was also very clear he was the executive. He was making the decisions. He was balancing all of those considerations. Because think about it. In that crisis, you had two good things that were in basic opposition to one another. One was to suppress the prevalence of the disease as much as possible, and the other was to keep the society and the economy going so people could eat and do the things that they need to do to create the essential things in life. Well, guess what? When what you're dealing with is a respiratory disease, what's the most effective way to drop it down to zero? Nobody go anywhere. Everybody sit at home. Don't have any contact with any other people. I can think of a major country on the face of the earth that tried to do that and failed miserably, and had lots of problems as a result. So, going forward with pandemic policy, going forward with guidance, going forward with executive orders from the governor required making that balanced kind of judgment, which again is properly the authority of our elected officials. And so again, in order to be prepared to go forward to the next thing, we need to go back and have a thorough after-action exercise, if you will. I would like to pull in not just elected officials and their staff and public health academics and public health governmental folks, but emergency management. I'd like to pull in journalists. I would love to have journalists participate in all of this so that they could really understand, what are these people thinking? What are they saying? So I'll go back to the expert vaccine allocation panel. Dr. Lakey was a member of it. There were 17 members on it. There were vaccine experts, all that sort of thing. My staff came to me and said, we'd like to have 4 members of the legislature participate in this as well. And I went, oh, my goodness, legislators on one of my committees. So do I really want that? Turned out to be the best advice that I ever followed, because because we had senior members from the House and the Senate who came. And again, Senator Lois Kolkhorst is a great example of it. They came and they participated in it, and they saw firsthand, these people know what they're talking about. These people not only know what they're talking about, but these people are taking into consideration exactly the things that I, as an elected official, would want them to take into consideration in terms of prioritizing who should get the vaccine first and how to distribute it. So to bring people inside the tent, if you will, and make them experience firsthand the competence that these people have. And by the way, one of my themes too is, we all know that we've lost trust. Well, what do you got to do to get it back? Well, first of all, you have to demonstrate competence, because only by demonstrating competence are you going to get trust. If you don't know me and you don't know what I do, and the first thing I do, I come up to you and say, yeah, trust me, go ahead, do what I say. What are you going to do? No. So we have to establish our competence, then we can reestablish our trust, and everything flows from there.
And I'm glad you brought that up, that allocation panel, because if you look at what we did, we went in a different direction than the federal guidelines.
Yep.
Because the federal guidelines were based on your job and were you essential, non-essential, et cetera. And I think it was partly because some of the legislators pushed us a little bit. Really, let's look at the data. And the data is clear. The people that were getting sick were the older individuals. Okay, and so we needed to protect the healthcare workers, that they're on the front lines. But then we went and started vaccinating the oldest individuals in nursing homes, et cetera, because the data showed that those were the individuals that were most likely to end up in the hospital and be sick. And so we went in a different direction. And I think as part of that trust that was developing between legislators and public health people and well-known scientists in the state, they were all talking together about how do we work together through this crisis.
And guess what? Much of the rest of the country followed our lead in doing that. And yes, it was the medically vulnerable population that we wanted to reach as well. Mm-hmm. But again, starting with hospital folks, because the hospital environment was unique. And if you went to work in that hospital environment during the emergency phase of the pandemic, you were in an environment where you were at high risk for contracting COVID. There's just no other thing like that. That's not the same as being an Uber driver, for instance. And so by protecting those folks and everybody, not just the doctors and nurses, but the pharmacists and the chaplains and the food service workers, in my experience of being a physician executive in a hospital system, I knew that every single member of that team was absolutely essential to keeping the hospital going. So like when you're really full, guess what the rate limiting step to open up a new room once somebody is discharged? It's the housekeeping folks. They have to come in and do a terminal cleaning of it. So all of these things had to fit together. And again, I think we bucked the trend, if you will. We were much more data-driven, much more science-driven, and we had a good consensus. And what was amazing to me is we outlined those priority populations. And I did not, at least it didn't get to my ears, I did not hear a tremendous outcry from people, from the public, saying, this is wrong, this is unfair. I think we communicated that very well. I think people understood what it was. But guess what? There was also a complicating factor here. The first vaccine was an ultra-cold vaccine. So you could take it, it had to be stored ultra-cold, you could then defrost it to the point where you were in a regular freezer. That was good for a week. Mm-hmm. But once you took it out and it was unfrozen and you entered that vial to give a vaccination, it had 5 doses in it. If you didn't give all 5 doses by the end of that day, you had to throw it away. Right. So that was the other message, is like, don't waste any vaccine. If you have a couple of doses left, go knock on doors, call people, see if they can come. Anybody who wants it can get it. So, and again, to have that kind of complicated and almost contradictory stuff, and to go through it and have people be immunized and have the public understand and accept why we did what we did, again, I think is a great example of doing it the right way.
Okay. Let's talk about measles. It's the first post-pandemic real test that we've seen for public health right now. How are we doing?
So last week we had 400 cases in the state. We had another 22 cases that have been reported. We've had 1 death in Texas, another death in New Mexico. There are now spread to many other communities. Very clear that it's in an unimmunized population and in a group that has hesitancy related to this vaccine. And I think the Texas Tribune has done a really good job at reporting on this event. I think we're still on the upslope of what's going on. I think the group of individuals that, and it's usually reported, in a Mennonite community is a little bit isolated. It's larger than many people thought. And I hear stories from colleagues in the medical profession that of significant concern in that community, of people seeing individuals with clear disease out walking around or working or other things right now. And I hear stories of when there is, and I'll be careful with story, people that I know that are involved in this, of when there is a individual with measles, of sometimes people getting together for intentional spread of getting infected in the family because of not
Measles parties. Yes.
measles parties.
Yes.
Because of a lack of understanding how deadly measles really can be. And again, I'm an infectious disease physician. I saw one measles case when I was working as a missionary in a hospital in Kenya. That was my measles experience. Knowing what's going on in that community right now, that just the people there are seeing lots and lots of measles, and I think it's hard to control the most contagious of infectious diseases in a community that may not fully understand how consequential this virus can be. That most of us, if we got measles, we would be okay. But when you get these large numbers and a death occurs in 1 in 1,000, but you're above 1,000 individuals, you start seeing people that will die. You start seeing people that will have the long-term sequela of this. It's a funny virus in that you can get over the disease and then many years later start having some of the neurological consequences of the virus. And so
that are fatal.
That are fatal, yeah. And so how are we doing right now? I'm concerned about how we're doing right now with this.
And I think the other point to make is that, based on the science of public health, in order to protect an entire community or group, whatever that is, so is that the classroom, is that the whole community, what are we talking about here? You really need to have a vaccination rate that's 95% and above. If you start to slip below that, then you're going to, if there's a case of measles sort of introduced into that community, you're going to have spread. And in that case, measles is so infectious that even people who were immunized are not 100% protected. So again, it goes back to a factor that is kind of complicated, I think, for a lot of people to understand. They don't really get that. But that goes back to, again, that herd immunity, that population immunity in a specific group. And so the immunization rates in many communities are well below 95%.
And there's significant people in our communities that are immunocompromised for a variety of reasons, and may have been totally immunized in the past, but because of their medications or disease or whatever, are no longer immune. And I guess one thing just to throw out there, the controversy about the vaccine, just want to be very clear, lots of data about the safety of the vaccine. I, as a father of 3, all my kids are fully vaccinated. Yeah.
Me too.
I will say I'm probably the only person in my newsroom that had it as a child because, childhood vaccinations were, it wasn't part of the regimen until 1980 for schools. And so there's several generations out there that did experience measles. And I also have a relative who had German measles while she was pregnant, and we've seen the effects of that. So, it is really concerning. I think also the stories that we're hearing too in West Texas is people are not showing up for, we have put a tremendous effort into vaccination areas and getting people vaccinated, but also no one's showing up for this. Are you kind of concerned that we are, you've noted you're concerned about where we are on this, but as a non-medical professional, this worries me about if this is the first test, what happens when, if and when, avian flu becomes a bigger issue for us? What happens in the next harder pandemics? Because you're right. It's not, if, it's when. And these are coming. I know that, I've listened to DISH's meetings all the time, and they're keeping their eye on Marburg and other diseases that could be coming. What are the things that we need to do right now, or as a state, what are the things that are not in place that we need to be doing to really get ahead of, I mean, what would you like to see? If you could wave a magic wand.
So I think there's several layers of being prepared for any type
Right.
of event. Can you detect it? Okay, and so and people don't like the word surveillance, but and it's not human surveillance, but looking for these germs that are out there, and there's new technologies that can be used, wastewater testing, a variety to be able to identify the next thing that occurs. You know, separate of measles, whatever occurs next, it'd be nice to be able to identify early. We need to be able to test quickly and get people tested, working with the healthcare community to educate and be able to make sure those systems of care are in place. Data, it was surprising at the beginning of the pandemic how many health departments, and sometimes large, that were using faxes to communicate to the Department of State Health Services. With some of the funds that they have received, they have been able to update those systems. But still, I hear there's gaps in that reporting, and that's really important so you know what's going on in your community. I think having supplies of medical countermeasures that you can bring in with avian flu, I think we're pretty good with the strategic national stockpile for Tamiflu and vaccine, et cetera. But and again, partnerships and incident command, I think Texas does that. But it's that communication and getting people on board. And there's always, it seems like there's at least two groups. Whenever the first group is whenever something's occurring, they get really anxious all of a sudden. And then there's this other group that no matter how much information is not going to get anxious enough, and trying to figure out how do you communicate to all of the society related to how do we coordinate the response to the event.
So, magic wand. I got a magic wand. My magic wand is I would love to have a system of influencers that were trusted voices in the community that could give what I think Dr. Lakey, and I know Dr. Lakey and I would say would be the real grounded truth about these diseases, and then particularly about vaccines. Again, one of the things about the pandemic early on, when it first started in 2020, all we had were what we called non-pharmaceutical interventions. So distance, face covering, masks, personal hygiene, environmental sanitation, all those kinds of things. We didn't have vaccines. We didn't have preventive or treating medicines that were really effective. And so you're asking people to change their behavior. And the things that you were asking them to do were unfamiliar and unwelcome. And so how do you ask people to change their behavior in a situation like that? Well, you need a trusted voice that's out there. And again, I think our elected officials did a great job in Texas in communicating it. That's we need not more than that. Or we need not just that, but more than that. Again, we all know about the effective so-called influencers that are out there, and their influence is driven by the algorithm, if you will, and the algorithm gives them feedback to say, the scary thing that you just said that really isn't true, it's getting you an audience. And so what do? They try and think of the next scary, untrue thing that they can get out there, because it's all about being driven by this algorithm and creating this audience. I'm all for free speech. What I need then, what we all need, is influencers who are just effective, that are fact-based.
And if I may add on that, I think there's a couple of layers of influencers, and we need the pastors, we need the media, et cetera. But also, having lived through a couple of these now, H1N1, Richard Besser, who was the director of the CDC at that time, I think did an outstanding job of being the voice of what's going on and talking and communicating at a very high level of the federal government. My experience is that the federal government is really important in these type of events. The CDC really does important things that supports states. In Ebola, I brought people that were the world's experts, to the event to guide us through this, epidemiologists, et cetera. You have to have a strong federal partner as part of that voice that coordinates that message, which I think Richard Besser did very well during H1N1.
And a reminder for those that are watching at home, H1N1, a lot of people have forgotten it. That was 2009, 2000. A lot of people know it as swine flu, but we did have a rise in cases. And I think, 33 people in Texas were died of it, which, now, which was one of the bigger events before the global pandemic. Want to turn the questions, what are some of the questions that you have that you or any other ideas that you would like to see the state, would you like to see a stronger maybe collaboration with local elected leaders the next time we come up against a pandemic or a health emergency? Did it seem like during this pandemic that we saw sort of like you had a messaging from Austin, but then you had all these different sort of local cities having a different message or coming up with their own requirements? Should it have gone to a more statewide uniform, or do you still want that flexibility where local officials can decide, for their local entities and their populations? There seemed to be kind of, you've spoken about messaging, and it seems like that's where some of the messaging
So I think
faltered.
I think there may be a couple parts to that answer. There's messaging and there's decision making.
Okay.
And I think, again, the elected officials, leaning on them as the voice that then sets the tone is really important. You saw some different decision making across the state that became political. And I think that's a separate issue. I also think it's a challenge in the age of social media where anybody with some credentials or not credentials that can get a following can influence a lot of people related to a variety of things. And I don't think we've solved that, and figuring out how do we let people know information that really is evidence-based. Is a medicine, has it really gone through a clinical trial and has been shown to be effective or not? And explaining that information versus other medicines that people would love would be effective, but we're because of social media influences, we're getting out there and not as effective. Or not effective.
And again, in my magic wand, in my fantasy dream, we really have a thorough going after action exercise that involves all of the key players in this communication piece. So it's elected officials, it's journalists, it's industry, it's public health, it's doctors, it's all of those kinds of things, so that they have an exercise with one another, and they develop trust with one another, and they understand why that other person is saying and doing the thing that they're doing, and it fits into their understanding of what the goal is. Again, I use the analogy of a war college. Why do they do it? They want to spread this common understanding throughout the entire organization, from top to bottom, because when the crisis hits, those individuals are going to be responsible for their own part of the response, and that's still going to be true of those politicians who want to do it a different way.
Thank you very much. I think we need to turn to questions. Am I right, Matt? I think we've got a couple of questions coming up. Sorry to cut off this great conversation, but
no, we have about 7 minutes or so for Q&A. Just a reminder for those here and online, you can submit questions at texastribune.org/ask. Sharon from Austin asks, with the significant cuts of funds, programs, and people by the federal government, including HHS and CDC, how can the UT system and its member universities fill the void? This person also asks, have you educated the Texas legislature about this sudden and significant loss and what it means for Texas and public health?
So since it said UT system, let me jump in. You know, can the UT system make up for federal funds that don't come in? That's not something we can do. But our institutions are leveraged in the midst of any of these type of events. And so if you look at when vaccine was first available, who was doing the vaccinations? It was our academic institutions. If you looked at who was doing the clinical trials during the event, it was our academic institutions. Where were they taking the first cases? The academic institutions. And so they play a key role in that. And our schools of public health and other scientists across the state were intimately involved in figuring out the science behind what was going on. I think that's, again, one of the key partners. And again, they kind of throughout this, it's partnerships that really bring us through these type of events. Educating the legislature related to the cuts, you would have to talk to the current department related to that. The one thing I would say about the funding cuts is because of the way Texas budgeted for one-time money, they're very careful to not budget a lot of ongoing costs, especially at the state, related to those federal funds. A lot of those federal funds would help us up our game with data systems and a variety of things that would get slowed down, and they'll talk to the legislature related to that. But the states that are going to be really in trouble were the ones that were reliant upon those dollars for ongoing staff at their state agencies related and local health departments for those services. And so the impact will be a little bit different, I think, for Texas than for some of the other states.
We have a question from Deborah from Lufkin. She's a public health nurse. I think it was touched on briefly, but she asks, as Texas focuses on pandemic crisis funding, how can Texas improve core public health funding for diseases which are, quote, old but here to stay, including tuberculosis and syphilis?
Excellent question.
Well, again, I would say that that is part of having a stable funding. We know that those are the core functions that are not related necessarily to an emergent pandemic response. And I think that now that the emergency phase of the COVID pandemic is over, that all the health departments are really back to trying to concentrate as much as they can on it. But a public health nurse, thank you for your service. You know how difficult it is, and you know that it's your personal skill and your ability to reach out to people that makes or breaks the effectiveness of those public health programs.
Yeah, I'd like to second that to any of the people that are out there that work in public health. You know, thank you for the work that you do. It's a lot of times you're not thanked enough for the work that you do out there. You know, I think we tried to make the case to the legislature related to, when we needed increased TB funds or HIV funds or syphilis type funds. And sometimes we're successful and sometimes we're not, but we try to keep, and state agencies still bringing it up and letting individuals know, and the legislature tries to do what they can. Along those lines, I think many of us are watching with caution what's going on in the CDC right now. And, a couple of the areas of the CDC that had significant reductions yesterday was TB, HIV, a lot of these other areas that I think are core public health. And it is not just the dollars that flow through, it's expertise and coordination at a national level.
Knowledge is key. And you really need to have that knowledge. And then when you take the knowledgeable people out of the system, then you have a deficit.
No, exactly.
No,
go
please,
ahead. No, go ahead.
Just a couple questions related to workforce after you, thank Deborah for her service. Marcia asks, I'm going to ask a couple questions as our last series of questions here. Marcia asks, how can we be better prepared to meet the spikes in health prof staffing needs at hospitals for the next PH emergency and preserve capacity in hospitals for other life-saving procedures such as heart surgery? But then there's Anne, who says, as a previous employee at DSHS, I see turnover as a big problem that results in huge loss of talented and committed people. What would you say to someone just entering the public health field about why they should work in state service, or are there better places to dedicate their time? Just a couple workforce questions to finish us off here.
Well, as far as going into public health, it is a sacred thing. You're working for the common good. And to me, there's no better way to spend your time and effort and talent. As far as being prepared for the next pandemic and preserving hospital capacity, again, that's where I go back to, you need in all of society understanding of what was going on. You need in all of society ability to coordinate a response and have effective crisis communication.
Yeah, and I'd agree. And again, thank you again to the people out there that worked in the hospitals or were on the front line, the primary care providers, the nurses, et cetera. They were on the front lines. And, it's a very different perception when I talk to healthcare workers versus people that were not involved in healthcare at all, especially at the very, very beginning of this, the angst and worry that people that were actually in the hospital, seeing people come in, had as they were looking at how many ICU beds do we have? What are we going to do with the next one when our ICU is full? How do we push out care to all the other places? It was a very different story for people that were actually in the hospitals versus people that were not in the hospitals. And likewise, I encourage people to go into public health. And I think this is a kind of a unique time right now, but I know there's students out there. I have found it incredibly fulfilling to be able to try to work on issues from a different angle versus a clinician taking care of just one sick person, to figuring out the policies, the infrastructure, how do we get smarter at keeping people healthy? And sometimes that's not recognized, but I do think there is a generation that's coming that went through this that are really interested in trying to solve these type of issues for us. So again, thank you for the young people that are interested in public health.
Thank you. This has been a terrific conversation. I thank all of you for coming. And I'll put a plea out there. If you like what you see from Texas Tribune, please go to texastribune.org and consider becoming a member. Thank you very much.